My name is Dr. Brian Harper. I'm the Chief Medical Officer at New York Institute of Technology, their College of Osteopathic Medicine. Just for your audience, just so that you're aware, I'm originally from Brooklyn, born in New York City, but raised in Brooklyn, New York. Went to a high school called Bishop Loughlin High School, which again is located in Brooklyn. Went to my undergrad at Brown University in Providence, Rhode Island. From Providence, I left and went to Syracuse for medical school. For medical school, I went to Harlem Hospital where I started my training in internal medicine. I left Harlem Hospital, went to SUNY Stony Brook where I completed a residency in preventive medicine and public health. From SUNY Stony Brook, I worked at the Nassau County Health Department for roughly 10 years as the director of their Bureau of HIV Services. I left from the health department and worked at the Nassau University Medical Center, where I was a medical director for 7 community health centers and their vice president for community health. And from there, I became the first African-American health commissioner in Suffolk County, which is in Long Island, New York. I subsequently left from that position and I served as the chief operating officer and medical director at a place called the Ralph Lauren Center for Cancer Care. And this is where I gained a lot of experience as far as cancer is concerned. And that entailed doing a number of presentations in the community, trying to get the Harlem community in particular to take advantage of many of the preventive services that we provide. From that position, I took the current position, and I'm now currently at New York Institute of Technology and was just recently promoted to the vice president for diversity, equity, and inclusion. Having said that, let's move on with the presentation. I'll first start off with a brief discussion about pathogenesis. Without insulting anyone in the audience, I think it's very important that we all have a understanding and a baseline of information of actually what causes cancer in any form. We'll also look at mortality data, some symptoms and screening activity for prostate cancer, as well as some things that we can do to prevent the spread or prevent someone from contracting prostate cancer. So first, let's start off with the fact that cancer is basically a disease in which abnormal cells begin to grow out of control. If you think about it, if you have a regular cell or if you have a regular organ, the question would be, why doesn't, for example, a liver continue to grow until it completely fills up someone's abdomen, or a lung continues to grow until it completely fills up the chest? The reason why this doesn't take place is because cells have normal signals that they respond to, such that they know when to stop growing. It turns out that in the case of cancer, these cells are not responding to these signals and this regulation appropriately, such that they begin to grow abnormally and continue to grow without anything preventing them from growing, and that's where they create many of the problems. It's important to note that cancers are named after the body part from where the abnormal cell growth begins, and that's oftentimes confusing. So if the original cell that begins to overgrow is, let's say, in the prostate, there's a possibility that that cell can now leave that prostate or leave that organ, go to another area of the body, which we call metastasis, and then begin to create problems in that other part of the body. And people will assume, for example, if the cell relocates to a bone and begins to cause problems and you have pathological bone fractures, then the individual will think that they have bone cancer, when in fact they may have cancer that actually originated in the prostate. And I guess I can use my grandfather as that particular example, in which he did develop prostate cancer, and which metastasized to the bone. And many people felt that he had hip cancer or bone cancer, but the truth was that he was suffering, unfortunately, from prostate cancer. So as I mentioned, cancer is caused by these abnormalities in a cell's DNA or genetic makeup. So the question becomes, what can cause these abnormalities to occur? So in some instances, they could be inherited from parents, but most likely they're caused from agents from outside of the body. So things such as radiation, chemicals, infectious agents, I'll talk a little bit about that as well. All of these things can change the cell's DNA such that they continue to grow and create major problems within the body. Substances that can lead to these changes or can lead to these genetic makeup changes are called carcinogens. So you may hear that term, and I'm just making sure that everyone is clear about some of the terms that we'll be using as we move forward. A good example of radiation exposure is, as you may recall, after the, I guess this was World War II, when the atomic bomb was dropped. Obviously, it did its major destruction and dramatic destruction as a result of the bomb explosion itself. But what became very apparent is that after the bomb exploded, there was a lot of radiation, and many of the individuals in that area came down with blood cancer or leukemia. That's when it became clear that radiation exposure can, in fact, cause certain types of cancer. We all know that chemical exposure, certain chemicals can also lead to certain forms of cancer. Asbestos is probably one of the best known in that it causes mesothelioma or a type of lung cancer. Certainly benzene and other chemicals can cause things such as bladder cancer and different types of cancers as a result of chemical exposure. Then we have this category of infectious exposure. So this is a sort of a new area where we're finding that certain viruses, in fact, can cause cancer as well. So hepatitis B is an example which can lead to liver cancer, and human papillomavirus is, again, it has been recently found out to be the cause of cervical cancer. So let's talk a little bit about prostate cancer and how it's actually diagnosed. The most important tool for diagnosing prostate cancer has been in the past a protein called the prostate-specific antigen, commonly known as the PSA. Now, what has been found over time is that this particular protein, when it's found at high levels in the blood, it may indicate that a person is at risk or may actually have prostate cancer. However, the data that has been used in many instances was not as strong as we would have liked it to be, such that in 2012, there was a very controversial recommendation to eliminate the PSA screening altogether because the data was not as strong as it should have been. And again, that caused a lot of controversy within the medical community. There was a group called the U.S. Preventive Task Force who was really making this recommendation not to use PSA, but many urologists and many other organizations felt that it was still important to use it in some fashion, despite the fact that the data wasn't as strong as we would have liked it to be. There were a number of long-term follow-up studies. These are randomized trials that demonstrated that there was no reduction in deaths as a result of PSA testing, which contributed to the reason why it was felt that it shouldn't be used. However, part of the controversy with this is that Black men were not represented well in these studies. They were only 4.4% in many of the USA studies that they looked at. The number of African-American men that were included were not, the number was not very high, such that you begin to question whether or not these recommendations are applicable to all people. We know that in the case of prostate cancer, there's certainly a higher incidence and higher mortality in African Americans, and that's why there's a question as to the validity of eliminating PSA screening altogether. And when we look at some of the studies that have been reviewed over time, you find that anywhere between 23 and 42% of men with prostate cancer detected by PSA tests have tumors that would not have resulted in any symptoms during their lifetimes. And again, this was part of the reason for the recommendation. Remember, in many cases, prostate cancer is a very slow growing tumor, such that even if it's diagnosed, that does not necessarily mean that it will cause you any problems in the future. And you may, in fact, die or succumb to some other disease before the tumor itself would grow to the point that it would create problems. So it became a very difficult test to use and be very forthcoming or be very confident that you could make specific recommendations based on the test alone. And we should also bear in mind that the PSA itself can be elevated due to a number of other factors aside from specifically prostate cancer. So if you have a urinary tract infection or a condition known as benign prostatic hypertrophy, or BPH, or even the actual digital rectal exam. So a part of a digital rectal exam is palpating or feeling the prostate. This, in fact, can increase the PSA level as well. Having said that, we know that if an individual has very, very high levels of PSA, it's the higher it goes, the more indicative it is that a person may, in fact, have cancer. In the past, the historical norm that was used was that if a person had a PSA above 4 nanograms per milliliter or more, then that was suspicious of being cancer, and a recommendation would be made that the individual would go on to have a biopsy, or perhaps just have what we call this concept of watchful waiting, or just maintaining or following the individual without doing anything further. Again, that's all based on the recommendation of the physician. So that's how it has been historically used. Currently, there is no cutoff number that's actually used. The recommendation is that the physician will review the need for a PSA exam. That's the first thing. So that becomes a very personal decision with the patient and the physician as to whether or not they'll even take a PSA test, as well as when those results come back, how they're interpreted, and what the next step should be. So for example, if you have an individual who may have a strong family history, meaning that they have a sibling, a father, other relatives who have in fact succumbed to prostate cancer, if the individual is fairly young, then that would be one of the reasons why you may be compelled to really do a PSA, particularly if they're coming in with some of the symptoms that I'll mention a little later on. Okay, so let's look at some of the data just in terms of some of the numbers. I wanted to show this chart, even though it's slightly old, but bear in mind when we're looking at mortality data for cancer, it tends to be, the data that you receive tends to be a little old because it takes a little while for all of the surveillance systems, particularly at the National Cancer Institute, for them to collect all of the data and then report on it. But this just goes to show you that overall, when we look at cancer deaths, that African American men and women tend to have a higher mortality rate from all forms of cancer, and this is United States data. If we look at lung cancer, for example, you'll see a similar graph in which, again, African American men in particular tend to have the highest rates of mortality. And I often share, again, looking at colon cancer, you see a similar graph. Again, African American men having the highest rates of colon and rectal cancer as well. So when you look at the African American community, they tend to have the highest mortality. So we're not talking about incidence or the number of diagnoses. We're talking about actual deaths. And you find that African Americans have the highest mortality, as I mentioned, in particularly African American men, lung cancer, colon cancer, prostate cancer we'll also look at. And in women, we have the highest mortality rates in breast cancer and cervical cancer as well. So cancer is a very significant disease in the African American community. I don't want to dwell on this very much. I know there's a prostate cancer presentation, but it's important that colon cancer, that we address this as well. And what I have here is a picture of a normal colon, which is seen with a colonoscopy, and then another colon in which there's what we call an adenoma. And the reason why I show this is because colonoscopy is still the gold standard for screening for colon cancer, because you can physically remove these adenomas. And we know that 1 in 4 of these adenomas will tend to go on to become colon cancer. So that's a very important screening tool, colonoscopy, because you can remove these adenomas. It's a little easier as a screening tool to use colonoscopy than it is to figure out what to do with the PSA. And I just show that for your information. All right, so getting back to prostate cancer. Now, prostate cancer accounts for 30% of all cancer diagnoses in Black men. And it's the second leading cause of cancer death in Black men. So remember, I showed some charts, and lung cancer would be number 1, but prostate cancer is number 2. And it's estimated that 1 in 7 Black men will be diagnosed with prostate cancer in their lifetime. So that's a fairly high rate. The good news is that mortality rates are actually decreasing in Black men, and I'll show you a couple of slides to support that. So if we go back to the earlier data that I was looking at, where if you're looking at the data in 2005 to 2009, so they look at that as a cumulative time period, you find that Black men had a rate of 53 deaths per 100,000, compared to our white counterparts of having only 22 deaths. So you can say there's a significant disparity there. Now, if you go to 2012 and 2016 data, you can see that 53 has now gone down to 40, which is a good thing. And even in the case of white men, the number has gone from 22 to 18. So the prostate cancer death rate is decreasing overall, but you can see that this is still a major disparity between African-American men and our white counterparts. Just to give you an example of some individuals, celebrities who have had to deal with prostate cancer, you can see Colin Powell, General Powell, Harry Belafonte, James Brown, Louis Farrakhan. All of these individuals have been diagnosed with prostate cancer. In fact, I recall conducting a presentation. This was Hunter College, and Mr. Belafonte was supposed to come and talk about his experience, and he actually couldn't make it to that particular conference because he was feeling so ill dealing with prostate cancer. I'm sorry, let me go back. All right, so what are some of the symptoms of prostate cancer? How would a person know that they may in fact have it? Oftentimes, patients will present with frequent or painful urination. They may have some blood in the urine. They may just present with back pain, or it may just simply be weight loss, and they'll come in because of weight loss. But in fact, as you begin to work the patient up and do the appropriate studies, you find out that they in fact have prostate cancer. Again, the screening tools that are available once a patient comes in, if the doctor is concerned, they will generally do the PSA test that we mentioned earlier, and the DRE, which is called the digital rectal exam. So you're physically trying to palpate or trying to feel nodules on the prostate. Now, the challenge with this is the location of the prostate is that it sits directly on the pelvis. So the only way to gain access to feel the prostate is actually through the rectum. So when the physician puts on his glove and his lubrication and he's feeling in the rectum, that's actually what he's doing, is he's trying to feel the prostate to see if in fact he feels any abnormalities. So the prostate itself should be the size roughly of a walnut, and it should be the consistency. If you remember the old pencil erasers, it should be that consistency. If you feel hard nodules on the prostate, then that's an indication that a person may in fact have prostate cancer. Now, again, the challenge with the PSA is that when they looked at some actual data on this, they found that for every 1,000 PSA studies done, it turns out that you then had to do 50 biopsies to find out if in fact the person had cancer, because if you do a PSA, the number is abnormal, the next step is generally to do a prostate biopsy. So that's a procedure in which actually a needle is put into someone's rectum to draw out some of these prostate cells and look at them under a microscope. And what they found is that for every 1,000 PSAs, you did 50 biopsies. And at the end of the day, you only found one person that in fact did have cancer. So you can see that there are a lot of procedures that are taking place that are unnecessary, and you're putting people through a lot of stress unnecessarily just to find that one cancer. And this was part of the reason why they started to look more closely at the PSA and make some recommendations about not using that. Again, it all depends on your risk, and that's why it's a very personal decision as to how to move forward. That has to be done with the patient and the physician making those recommendations. And then how do you treat it? Ultimately, you're going to use broad categories. Are going to include surgery if you find that someone comes in, particularly at the end stage, and they have the cancer has broken through potentially the capsule of the prostate. Either way, it's a decision that has to be made as to whether or not you're going to remove the prostate completely, try to treat it with hormones, some form of radiation, or you have the seeds or radioactive seeds that can be implanted into the prostate as well. But we're not going to talk a lot about treatment, but this just gives you a general sense of some of the things that can be done. So as we talk about this issue about health disparities in cancer, this is just to show that there have been a number of documents and books that have been written about addressing this disparity in prostate cancer as well as in cancers in general. And it's been taking place over the course of the past 20 years or so, actually probably more than that, 30 years or so, looking at this particular issue. And at the end of the day, it's going to be a combination of things that lead to this high mortality rate. One of the major factors is going to actually be poverty and low economic status. So if an individual finds themselves in a lower economic grouping, they tend to be living in areas that may have more of those environmental factors that put a person at risk for cancer. So that's one of the challenges. If you're living in poverty, you tend to be less likely to have insurance. You tend to be less likely to be educated and read up on issues to know about preventive activities that can take place. You tend to live in areas where the quality of food is poor. You may not have access to fresh fruits and vegetables. You're living in areas that we call food deserts. All of those things can contribute to putting you at a higher risk for cancer in general and prostate cancer in particular. And I'll discuss that a little further in some of the future slides. Then you have the whole concept of social injustice. So even oftentimes you'll find that when two individuals, you have an African-American and an individual who's white, and they have equal socioeconomic status, whether they're both poor or both rich. When they enter into the healthcare system, for some reason, the outcomes tend to be better when you look at large numbers for the white community than for the Black community. So that we know that there's something going on as far as social injustice, and this is within the healthcare system. There's still a lot of work to be done in that area. And then there's the area simply of culture. So culture is going to include the foods that we eat. What type of lifestyle do we have? Do we have a sedentary lifestyle? the things that we're doing leading to being obese. All of those things can have an influence from prevention and early detection all the way to survival and mortality. Well, those three factors play a role in every case. This slide, I won't dwell on this for now. So the question becomes, when we're talking about prostate cancer prevention, there seems to be more and more evidence that's suggesting that obesity and smoking may be associated with an increased risk of aggressive disease. And some studies are actually showing that these linkages between this aggressive form of prostate cancer and obesity and smoking, those links themselves may be stronger for African American men. So we know that all forms of prostate cancer are not the same. As I mentioned earlier, you can have some forms that are very slow growing, such that even though you find cancerous cells within the prostate, that those cancerous cells never get to the point that they create a problem for an individual. And they may, as I indicated earlier, they may succumb from a heart attack or some other medical issue before the cancer even plays any role whatsoever. So it's important that we need to be aware of that as we sort of address that. But the challenge that we have, the diagnostic challenge, is that it's very difficult to distinguish. Is this going to be a cancer that we have to be very concerned about, or is this going to be a cancer that we don't have to be concerned about? And one of the only ways to really ascertain that is by going and doing the prostate biopsy and actually looking at those cells and trying to make some decisions based on that. Nonetheless, given with the data that we currently have, some of the ways that we can certainly try to prevent prostate cancer is, number one, obviously discontinuing any use of tobacco. And this is smoking tobacco. These things that just leads to putting you at a higher risk for, you name the disease, whether it's going to be lung cancer, prostate cancer, cardiovascular disease. Smoking is just not a good thing to do if you're concerned about improving your health. Obviously, increasing physical activity. This idea that obesity, and what they're finding out is many of the risk factors for cardiovascular disease seem to be risk factors as well for prostate cancer. So increasing physical activity, watching your diet, reducing overall caloric intake, reducing fat intake, obviously increasing vegetables and whole grains, and decreasing red meat. There's a lot of evidence to suggest that vegetarians in general are going to be at a lower risk for cancer in general, as well as cardiovascular disease. So all of these things are things that can be done to help prevent cancer. But there may be a portion of this that if you have a genetic predisposition, you may in fact be dealing with a prostate cancer issue despite engaging in preventive behaviors. But it's always best to be as healthy as possible, even if you are diagnosed with cancer. I often share that no matter what the situation is, if you're obese and you have to go into surgery, you're not a very good surgical candidate. The likelihood of you having a poor outcome is going to be greater if you're obese. So, and that goes across the board. So whether you get into a car accident and you need immediate surgery, it's always better to not be overweight and be in as good shape as possible in case something would occur that you had to go to surgery. And I think at this point, I'll probably end it and entertain questions.
Doctor, we've been admonished by doctors at healthcare institutions to avoid non-emergency appointments. I've missed my annual physical. Should I wait until next year when it may be safer to go to the doctor's offices and hospitals?
Okay, well, that's been an ongoing issue, and a lot of this relates to the the current pandemic of COVID-19, so that people are looking to avoid the hospital setting because of concerns regarding COVID-19. The message that has actually come from the New York City Health Commissioner, as well as the State Health Commissioner in New York, everyone is recommending that you do not postpone that. It's very important that you do go and see your physician and make sure that you have the appropriate studies. Oftentimes, particularly with cancer, the sooner that you become aware of it, that often helps with the overall prognosis. So it's best to be aware of any disease, in fact, but cancer in particular. The sooner you know, the better. So I would recommend that you continue and move forward and have your annual physical. There are now ways that we're becoming more attuned to, just as we're doing here with a Zoom meeting. There's this whole new area of telehealth, so that in fact you may be able to have an annual physical, or at least an annual encounter with your physician, who can recommend the appropriate studies be done without necessarily going into a facility. But you don't want to delay that. You should go on and go to your annual physical.
Dr. Harper, I'd like to thank you very much. This has been a very enlightening discussion. One of the questions that I have for you is, what about communications with family members, spouses, relatives, and friends? How would you suggest we communicate with them in regard to the prostate cancer?
Right. Well, cancer, unfortunately, is a disease that affects the entire family. Ideally, if an individual, and we encourage communication between, obviously, a spouse and a husband, we encourage that sort of communication. In fact, it's helpful oftentimes if both people come in to see the physician to address these issues. We're trying to, in fact, reduce any stigma associated with cancer. There was a point where just mentioning the C word, that it was very secretive and no one would mention that. But it's important that we all acknowledge the importance of it and the need for us to come in and be treated, and remove any of these myths regarding cancer. It's also important that we talk about it with our families, because, as I suggested, these things have implications for other family members. So if you don't share with your brother or your son or your other family members that in fact you have cancer, they may not in fact realize that they're at higher risk and should be screened more appropriately. And all of these things are decisions that need to all of this is information that physicians need to make quality decisions as far as the next step is concerned in either diagnosing or moving forward with addressing prostate cancer. So we encourage family discussion.
Yes, sir. Thank you very much. I know that you touched on this before, but could you reiterate again the importance of watching your diet and watching or being, physical in terms of exercise? Can you just reiterate on that?
Yes, I think there's nothing more important that we can do than watching our diet and exercising as much as possible. Remember, that not only reduces our risk for, now it's becoming more apparent, for prostate cancer and other cancers, but also cardiovascular disease. And remember, cardiovascular disease is still the #1 killer of people in the community, African Americans in particular, but that's still a major killer. Cancer is probably going to be a second or third on that list. So it's very important that we exercise to reduce our risk for all of these various diseases. And the sedentary lifestyle, so that's just being at home, not exercising, your heart not beating, that just leads to inherent problems. It puts you at a higher risk for diabetes, and these things work in collaboration with each other. So if you're sedentary, you gain weight, now you become diabetic. If you're diabetic, you're at a higher risk for a variety of infectious diseases. You don't heal as rapidly. There's a possibility now you may injure yourself and you don't heal properly, so then your extremities may become infected. that could lead to amputations. And it's sort of a slippery slope that we're looking to avoid. And that doesn't even begin to even address the orthopedic problems that come along with, with obesity. Then you begin to have knee problems and other, other joint problems. So I think keeping the weight down is one of the best things that we can do. And the sad part is that, part of it is cultural. So as I mentioned in my previous position with the Ralph Lauren Center, I would go out to churches and try to really encourage people to come and be tested and engage in all of these preventive behaviors. And I would talk about diet. And after doing my presentation, the pastor would say, "Boy, Dr. Hopper, that was a great presentation. And I hope you're going to remain with us and have food and, and what have you after after church." And that's part of the culture. So I would do it, and I would sit there and eat all of the fatty foods. So whether you're talking about macaroni and cheese and fried chicken, all the things that I love as well, and that's part of the culture. So that's some of the things that we have to do to at least limit, the amounts of food and watch our caloric intake. It's hard to not do it at all, but at least you want to do things in as safe a fashion as possible. And I think that reducing the amounts is as important.
Thank you, Doctor. Edwin?
Dr. Harper, I really appreciate your discussion about the emotional and physical management of the situation. But do you foresee ever a cure?
Yeah, well, that's going to be a challenge. It's hard to say that there'll be a cure, but you never really know. I feel that there may, and I don't have a lot of hard data to support this, but if you notice, I mentioned in passing that they found that there are infectious causes for some cancers. So when we looked at cervical cancer, they became aware of this human papillomavirus that ultimately causes, and this is in women, to develop cervical cancer, and as well as the hepatitis B, which leads to liver cancer. So in the back of my mind, I'm always curious and wondering whether or not there could be some infectious reason why why we have this increase in prostate cancer. Again, no hard data to support that, but I just keep that in the back of my mind. So that would be one area that I would think should certainly be explored. Other than that, it's going to be some of the treatments that we currently have. So one of the things about cancer in general is that those cells, those cancerous cells, tend to grow more rapidly than your normal cells. So all of or many of the treatments that we currently use are looking to focus on cells that are growing rapidly in general. So that's why many of the chemotherapeutic agents that we take, they're going to attack those cells that are growing most rapidly. So our hair cells grow very, very rapidly, if you have hair. And then the cells that are in the gastrointestinal system, they grow very rapidly as well. And that's why people often have nausea from taking these chemotherapeutic agents, as well as they'll lose their hair, because it's sort of a general approach to killing cancer cells. So what they're coming up with are a lot of sort of more strategic ways of focusing in on cancer cells. And I think that some of those areas are very promising. So then rather than attacking all of the cells with these highly toxic chemotherapeutic agents, if there's a way that we can focus specifically on prostate cells that are growing abnormally, then that's probably the most promising thing that we're seeing in the future. And they're making a lot of progress, particularly in some of these academic centers, Memorial Sloan Kettering, where I was previously affiliated with. They're doing a lot of work in that. But there was one slide that I skipped, where I wanted to talk about the issue about the progress that's being made. So we have to be very careful that when we have all of this academic and scientific progress that's being made, the question becomes, do the average folks in the community have access to all of these fantastic treatments that are becoming available? And I believe that there's a little bit of a disconnect there as well. So it's not only the academic and the scientific studies that are being done, but we have to make sure that we can give all of this new academic knowledge, we can get that into the community so that it really helps the average person who may not be rich enough to have the best doctors at Memorial Sloan Kettering.
Thank you, Dr.
My pleasure.
Thank you again, Doctor.
Okay, I hope this was helpful. Thank you for having me.
Extremely helpful, yes.